Hi, this is Dr. Phil Smith talking to you today about Introduction to Clinical Business Intelligence, leveraging data analytics for improved patient care. The objectives of this talk are to provide you an overview of data analytics in healthcare, define what CBI or Clinical Business Intelligence is, give you some examples, summarize a roadmap strategy around your clinical business intelligence, and learn a few caveats that you may find useful for your CBI efforts. A little about me, your speaker. I've been in healthcare for 40 years. I'm board certified in family medicine and clinical informatics. I've been a physician assistant in surgery. I went into private practice after residency. I adopted an electronic medical record back in 1993, and from there leveraged that into entering the field of informatics, where I've served at the vendor level as a consultant, as a chief medical officer in healthcare operations, 12 years experience as a chief medical information officer, and I'm the author of Making Computerized Provider Order Entry work, published by Springer out of London in 2012. So let's start by talking about data analytics. And I like to break data analytics into three different areas: financial, operational, and clinical. Historically, healthcare started out first with financial analytics and has been around for 40, 50 years. And this includes our traditional accounting methods such as profit loss statements, balance sheets, cash flow statements, and the measure called EBITDA, which is earnings before interest, taxes, depreciation, and amortization, which is a good reflection of our bottom line before we take these other measures for tax purposes. And it's often used to compare hospitals against each other. PricewaterhouseCoopers, over a decade ago, presented this chart of how we move from data to information to knowledge and on to wisdom. And today you often see it represented with two more bubbles, one for prescription and another one for prediction. But let's start with data. If I tell you 3.5, you're not really going to know what I'm talking about because it's just a data point. So I turn that into information by saying 3.5 millimoles per liter is the current serum potassium level. Well, that gives you some information, but again, I'm lacking context of how that information is important. So I might say that a normal serum potassium level is 3.5 to 5.2 millimoles per liter, and the patient's current level is 3.5 millimeters per liter, which then lets me know that the patient's serum potassium is in the normal range. Now, wisdom might be applied to say, okay, the potassium is currently normal. How do I keep it normal, and how do I prevent it, since it's on the low end of normal, to go into the abnormal range? And prescription would be saying, what do I need to do differently to improve that potassium level? And prediction is, what's the likelihood that that serum potassium level is going to be below 3.5 millimoles per liter in the next 24 hours. So you can see that as we go through this journey from data to wisdom and on to prescription and prediction, this is increasing complexity to pull off and increasing interactions and interrelationships from data all the way to prediction. So let's talk about operational data, which is what many hospitals are familiar with. The first one is length of stay, or LOS. That has to do with the time that a patient is in the hospital. So that could be based on an average length of stay for all patients, an average length of stay by payer, an average length of stay by diagnosis group or diagnosis, or an average length of stay based on comparing hospitals to hospitals. But it's a very common measure. Cost per case is pretty obvious. I might want to look at a typical case, and this could be a surgical case or a medical case. So in a surgical case, it could be the cost per case of total hip replacement. A medical case would be the average cost per case of treating a patient with decompensated congestive heart failure. Supply chain refers to the supplies and things that we put into patients. Example would be orthopedic implants such as total hip prosthesis, could include pacemakers, could include central line catheters. Supplies could include things as simple as latex gloves, tongue depressors, topical agents, and medication costs are pretty obvious. This would include our pills and our IV or intravenous medications. Could include complex feeding supplements that we give intravenously. And then laboratory operations has to do with our operation of our inpatient and our outpatient laboratories. We could be a reference lab, which means that we do test for more than our facility. So we might bring in information from other laboratories and serve as a reference lab. And we want to know how we're doing in each of these labs because typically the inpatient laboratory either breaks even or loses money, where the outpatient laboratory where we can actually bill per test done is usually our revenue center. And if we're a reference lab, we probably would be our highest revenue center. So we'd want to monitor those broken up in those categories to know how we're doing and to be able to tell if a test is properly priced to cover the cost of performing the test. There are some operational data that we look at from a defensive standpoint. Readmission rates has to do with how often patients get readmitted to the hospital after discharge. Now, this is a tricky measure because they could be readmitted to our own hospital or they could be readmitted to someone else's hospital, but we're reflected on that by Medicare, for instance, and they penalize hospitals currently 3% of their Medicare reimbursement based on whether or not their readmission rates for several diagnoses are at or above the national average of other hospitals. So we certainly want to monitor that, and if our readmission rates are higher than our peers, we want to do something to manage that. Actual length of stay has to do with, at the patient level, how long a patient actually stayed. Anticipated DRG length of stay has to do with our anticipated length of stay that should occur based on that surgical procedure or for that medical condition. So for instance, a congestive heart patient might be expected to stay in the hospital 5.2 days, and that would be our anticipated length of stay. And our actual length of stay could be shorter or longer. So if the actual length of stay exceeds the anticipated length of stay, then we then classify those additional days as unreimbursed days because we're not being reimbursed for the cost of those additional days. And that's a measurement of how well we're doing based to peers, which are established through benchmarking all the hospitals across the nation and how they perform based on various diagnosis-related groups. And if you're not familiar with diagnosis-related groups or DRGs, those are the payment categories or payment buckets from Medicare based on a diagnosis. And they typically have 2 buckets for every condition. So for instance, there might be a bucket for congestive heart failure, and then there might be a bucket or a standard payment for congestive heart failure with comorbidities. Comorbidities are additional disease considerations. So for instance, if a patient has congestive heart failure and has other diseases such as cancer, high blood pressure, heart failure, which obviously is their core disease, or come in with pneumonia, those would be complications or comorbidities. Market share has to do with how we're performing within our market. So for instance, let's take a metropolitan area that has 2 large health systems and then a few scattered individual hospitals, where hospital system A has 50% of the market share and hospital B has 42% of the market share, and then all the other hospitals collectively have an 8% market share. So hospital A and hospital B are going to be looking to try to improve their market share and gain more of that market, either from their major competitor or from the smaller competitors. And you want to know, is your market share growing, staying the same, or decreasing? Payer mix has to do with who's paying the bills. So your payer mix might include military health, might include Veterans Administration overflow, might include Medicare, Medicaid, might include self-pays, which are people that don't have any type of third-party payer, and then what we call commercial pay, which has to do with standard employer provided insurance, such as Blue Cross Blue Shield, United Healthcare, and so forth. Now, clinical data, which is the focus of this talk, some typical things that we look at clinically is we want to know what our mortality rate is. So mortality is a death rate, and mortality can occur either while in the hospital, related to the medical condition, could be a mortality that occurs after surgery, or could it be a out of hospital mortality that occurs within 30 days of discharge. So we want to know those rates and how we perform based on our peers against benchmarks. Sepsis rate have to do, sepsis is overwhelming infection in the body, has typically a mortality rate of 50%. And therefore, we want to know what is our incidence of sepsis and what is our actual mortality rate of the sepsis cases that we have. And we want to be moving that number to a smaller and smaller number, both against the national benchmark and within our own internal numbers. Never events have to do with events for which Medicare and other payers won't pay us for. And never events are things that should never happen in the hospital. So for instance, we should never do an operation on the wrong patient. We should never do the wrong side of surgery. So if they're coming in to have their right knee replaced, a never event would be accidentally operating on the left knee. Never event would be leaving a foreign body within a person's abdomen during surgery. So that has to do with the proverbial leaving an instrument or a sponge inside the abdominal cavity after abdominal surgery. These are things that should never happen and are in fact things that we should not expect reimbursement for. So these affect our bottom line, and we want to know when they occur, not only because we have to report them, usually to our state and to our accreditators, such as Joint Commission. But we also want to do what's called root cause analysis and figure out what went wrong so that they never happen again. Morbidity can be used to look at morbidity of the patients coming into our hospital. So for instance, of our patients with congestive heart failure, what percent are diabetic, and are we doing a good job of managing those comorbidities? And it can also include hospital-acquired events, such as things that occur after they're under our care. So for instance, a hospital-acquired event might be a patient on a ventilator who gets a pneumonia. And two others that are measured are CAUTI and CLASP. CAUTI refers to catheter-associated urinary tract infections, which have been shown to be decreasable if we can get the catheter out of the bladder within 24 hours. We can lower that rate, and if we do better care on putting catheters in and minimizing their use whenever possible. CLASP stands for central line associated bloodstream infection, and this has to do with a central line, which is a catheter put into a vein such as the subclavian vein or the femoral vein or the jugular vein, and we want to make sure that we don't get a secondary infection from having this foreign catheter into the bloodstream. And so there have been numerous studies showing that we can reduce this number to near zero by using very meticulous technique of putting the catheters in avoiding their use whenever possible, and minimizing the duration of which these catheters are in place, especially if they're put into the femoral artery in either the left or right groin of the patient, where there's a higher risk of infection if those are left in more than a day. Clinical business intelligence is defined as really the process of turning clinical data into useful tools to both influence and improve care. And we're going to talk about presentation of clinical business intelligence and how we use trends, how we look at comparisons among providers, how we benchmark to populations, like I talked about readmission data, benchmark to the National Medicare database, what control charts are and how we use them to better understand what's happening within our health system. And then finally, I'll show you some examples of some live dashboards placed essentially within the electronic health record so that they do compelling presentations of data with the endpoint of changing behavior of the clinical care team within the context of what they do at the bedside of the patient. So if we look at the first example, let's talk a little bit about trends. And on this subject side, you can see I've got a downward trend and an upward trend. And I think most of us are familiar with trends at some point. So in order to have a trend, you have to have data. And if you look at data in this example, you'll see that the data is based on total blood units transfused per month, and it shows a month-to-month breakdown of this information. But it really doesn't tell you a whole lot about the organization. Notice that the data doesn't tell you any context of how many patients you treated, how big your facility is, what your target is for transfusing, or any other information. So this is just a presentation of raw data, and it could be done in a table form, or in this case, in a histogram form. Now compare that to this, which is more of a trending graph. You'll see several bits of information. In this example, we're talking about transfusion positive patient versus product identification. And this has to do with when you're transfusing the patient, are you scanning the unit of blood, and are you scanning the patient's armband and making sure the right unit of blood gets into the right patient? So in order to do that, we see a couple things. We see scanning of the blood product is represented by a red line. Scanning of the patient ID badge is shown by the blue line. And you see there's a red line at 95% showing that that's our performance goal, that we want this to always happen at least 95% of the time. So not obviously we want it to always happen, but we're not going to accept if we fall below a 5% failure rate. And you can see that this organization actually is performing close to 100% with only a few outliers, and the overall trend seems to be holding steady on the blood product, although we have some opportunities from time to time on getting the armband of the patient scanned. So you can see how this graph literally gives you multiple points of information, very easy to consume, and gives you some context because it's based on a percentage of performance, not on the number of units. But it would be helpful to know the number of units, and perhaps overlying these two graphs would be helpful. So putting them side to side, you can see that both of them are related in telling the story about what's going on. But I would argue with you that the trend lines show more of a story than just the data by itself. And this is more of a move into clinical business intelligence and influencing people's care, especially if you publish this data on the nursing units so that the nurses clearly see how their performance is. And perhaps you'd want to take the data and display it by the nursing unit so you could see the best performers compared to the worst performers, and even better, show multiple graphs showing the different units performance against each other, which would be benchmarking internally to each other on the units. So let's talk about comparisons across facilities and providers. So here's an example of some clinical closed dashboards, which are great examples of comparisons. You'll see that this is a trend of how a hospital is performing across the month. It shows data about multiple criteria such as performance against stroke, measures against venous thromboembolism measures, which are blood clot prevention, about sepsis, about prenatal care, and things such as immunization rates and getting patients to the thrombolytic lab or the cardiovascular lab for interventions within 90 minutes. So it shows a lot of data on there. And on the bottom, it has data over a 1-year period in the form of spark lines, which are those little lines in the middle of the bottom graph. And it shows hospital-acquired infections on the right and showing that they totally eliminated any mortality from hospital-acquired infection. So this is a great visual showing how a hospital can monitor itself and show comparison across different measures and across different units of care and about different people. So if you go to the next level and drill down on this, they actually have the data presented by the individual doctor level on each of these measures. So this is an excellent example of how an organization could improve their performance and look at who's getting it right and who might not be getting it as right. So what's a control chart? So control charts are literally a way to determine is the process that you're following or the processes you are following, are they due to random chance or are they due to a process that you're doing? And so we all know that there's what's called the Gaussian curve, and that one standard deviation defines around the mean what happens 67% of the time. If you go out 2 standard deviations, that defines what should be happening 80% of the time, and 3 standard deviations should be out showing what happens 95% of the time. So those 3 standard deviations define what's called an upper control limit and a lower control limit. And you're looking for your regular data, in this case monthly data, to fall between the upper control limit and the lower control limit. And if they do consistently, then you know your process is in control. And occasionally you will have a value outside of the upper or lower control system. And if you look at the graph to the bottom, you'll see that there's 1 point above or outside the upper control limit, and you'll see that there's 1 point at or below the lower control limit. But overall, there aren't multiple values outside. So it looks like your process is really within control at this point. Now, live dashboards are something that's relatively new within the electronic health record, and I'd like to compare them to the scoreboards at major sporting events, where you can look up at the scoreboard and not only see what inning of the baseball game you're in or what quarter of the football game, but you can see player stats, you can see team stats, you might see a video of what's happening close up on the field, you might see an instant replay, and of course you might see your traditional beer advertisement. But the idea is all that data is presented in one place in multiple formats, and it really allows the mind to consume a lot of data with just a glance. So this is one health system solution, is to create a sepsis dashboard that looks at the temporal relationship of what's happening with an individual patient over time. And this graph is depicting that there's a time at which sepsis is recognized. There's a time that antibiotics are given and that IV fluids are given and the blood cultures are obtained. And those were all done within what's called the golden hours, which are defined by the two red lines vertically. And that's your performance level of what you want to do. And then you can follow out subsequent doses of antibiotics, subsequent blood cultures, and other events that are occurring. And that is looking at the individual view, and now this is looking at all patients' view and showing the trends of the organization. So as I said, sepsis mortality typically runs as high as 50%, and this hospital is at a 9.9% mortality, which is an excellent reduction of, that would be an 80% reduction in their ability to prevent mortality from sepsis. So let's talk about how we do a roadmap around our CBI strategy. So I built this diagram to say that all business intelligence should really be governed and have some type of governance and intake process. And so before you go out and start writing a lot of reports or creating a lot of analytics, you need to decide what your information governance is and how you're going to intake projects to do clinical business intelligence, because you do not want that to be an open door where you're getting inundated with a lot of report requests that are tying down your analysts who are building these reports and your clinical people that are advising them on how to do it. So for instance, you always want to know what the source of truth is for data. So let's take you through this. So the first thing you want to do is when there's a request for some type of clinical business intelligence tool, such as a dashboard or a report or some other tool, you first want to define what the business requirements are. So in other words, what's the data you want to look at? What's the purpose for looking at data? What is the source of the data? What is the benefits of having the data, and how are you going to leverage that data once you have it to actually either improve care, cut operational cost, or improve profitability? The next step is to identify your subject matter expert or experts. And these are the people that are closest to the data. So for instance, if I'm looking at the obtaining of EKGs within the emergency department, I might want to understand the process of how EKGs are obtained in the emergency department. What are the current protocols and rules in place of when we get an EKG? Does it require a physician order specifically, or is it done by some type of chest pain protocol? And who actually performs it? So I want to get some background on it, and I want to be able to talk to somebody who is actually involved in the process who can guide it. And a common mistake is that someone will go to management and say, tell us about your process, and the management team may not be close enough to the process to actually identify all the different steps. So you really want to work with someone who not only sees the big picture, but someone who is willing to go in and find out what the end users are actually doing. Then we want to identify where the data source of truth lives. So for instance, in hospitals, there are often multiple locations where people chart data sources such as registration systems, which may time your process. So for instance, what time did the patient check into the emergency room, and at what time was the EKG done? Well, the time the EKG done may be coming from a source such as the EKG machine, where the time the patient arrived may be in your registration system within the emergency department. So you want to know where the source of truth is for each data element you are looking at. Then you want to scrub and validate that data, and we do that by looking at where data not only lives, but look at, is it always accurate? So for instance, what's the error rate? Is it data that's actually captured? Is there duplicate data? Is there data that's misentered? I've seen hospitals, for instance, that are doing reports based on birth weight of infants, and then find out that the birth weight is actually allowing more than one value to be put in. And unfortunately, the birth um, weight, which should be the literal time at birth, is actually populated with 3 or 4 values indicating the daily weight of the infant during the first few days of the hospital. So in that case, I would want to say I always want the first instance of that data and ignore subsequent instances unless the first entry was invalidated or placed in error. So I have to be able to look at my data and say, is it valid or is it not? Then I want to create some type of preliminary report and have an actual user of the data validate that report. And much like talking about proofreading your high school or college term papers, you really don't want the person building the report to be the person validating it. It really needs to be a person close to the action who can say, does this report accurately reflect what is actually happening at the bedside? So for instance, I remember a case where somebody came to me with a report looking at performance of national quality measures in the emergency room and said that the ER physicians were not getting EKGs on patients coming in with chest pain. Well, it's pretty obvious that that's not the case, and where someone was looking for an order by a physician put in specifically for an EKG, they really should look at the actual performance date and time of an EKG, since these are often done through a protocol type of order, not requiring physician initial entry, but may be done through an established protocol in the hospital. So where that might work as a legitimate data point for other interventions in the hospital, the EKG for the chest pain patient may not be valid. So you don't want to be embarrassed down the road to know that your report doesn't accurately reflect what you're trying to measure. And this also, you'll see this arrow coming in from the bottom that says conform to style guide. And by that, I mean, you really as an organization need to define how data should look. And in cases where you have multiple reports being produced, try to create some common themes on how the data is presented so that if you're creating 15 to 20 dashboards, the user can look at them very clearly and see what's going on and decide where they want to further drill down to the data. So if I'm always showing performance on the positive with a line showing me below which I don't want performance, and then all of a sudden I switch that and turn that upside down on another report where a number above the line is actually not desired, that creates confusion. So you want to try to keep into a common style guide in your efforts to build reports and dashboards. And finally, you want to publish your final output. And true clinical business intelligence should be easy to consume from anywhere, any place. So that might be posting it on your intranet of your organization, pushing it out to secure connections to cell phones, to iPads, and into the electronic medical record. Because ultimately you want this data to get to the people that are going to change their behavior as a result of seeing the data. Now that could be policymakers, but that also could be the bedside clinicians, nurses and doctors, or pharmacists who are using the data for their day-to-day operational improvement. So let me give you a few caveats of clinical business intelligence that I'd like you to take home from this talk. Always, always, always make sure that you have a source of truth and that it is indeed the source of truth and not a proxy for the source of truth. So in other words, if the data initially resides in one location, try to get the data directly from that initial source of truth, as opposed to some other inference of what the source of truth is. Second, clinical business intelligence has to be delivered in a timely method. I see organizations often working on 3 to 6 months, sometimes a year later, and trying to make correlations and change behavior. In fact, many health systems are looking at readmission data from 6 months to 3 years old and trying to decide what their current problems are. And you really can't influence people with old data. For instance, I've always said it does no good for me to go back to a doctor and say, doctor, you didn't do something 6 months ago. That really doesn't change behavior because the doctor just looks you in the eye and say, well, what do you want me to do about it now? So you want the data to be as fresh as possible to correlate to actually what you're doing today. And if all possible, you want that data to be real time, meaning you want to give feedback so that you can actually influence behavior while the patient is still under your care. Thirdly, the data must be compelling. So your output should be a call to action. And if it's not a compelling call to action, you probably will not see people change what they're doing just because you tell them they need to change. So think about how the data is presented, and is it easy to consume and to move someone from where they are today to a better location. And ultimately, it should be presented for rapid consumption. Don't make me go to some handbook to look up data definitions or what the data actually represents. Try to state it as clearly as possible, not to clutter up what you're doing, but perhaps provide pop-ups or hover type of information or data tables, data dictionary, things that's going to help your users not make false assumptions about what your clinical business intelligence tool is actually trying to tell. And always remember, the right presentation of data information should create a compelling call to action and not just reporting. So if you want more information on health IT, please visit healthitaccelerator.com and feel free to email me at psmith@healthitaccelerator.com.